Dr. McCaw.
Well, it's fitting that I'm the last presentation because Mark started us out with, helps to turn on the microphone. As I was saying, it's fitting that I'm the last presentation because Mark started us out with the question of what is violence and left us with the question of what do you do about it? And that's what I hope to present to you today. It is possible to take the science from an evolving area like violence prevention and move it into on-the-ground practice and then bring those learnings back to make the science better. And what I'd like to do is share with you today an example of practice-based evidence and describe what we've done in Kaiser Permanente using a systems model approach that has been associated with a 7-fold increase in identification of family violence, specifically intimate partner violence. And we've been able to disseminate that process through all of Kaiser Permanente over the last decade. And what I'd like to do in that process is highlight a couple of things that I think were instrumental in success. And one of those is the clinician-researcher partnership. Another is ongoing quality data that drives implementation and sustains a program. Another is technology enablers like the electronic medical record. And then the last is the usefulness of implementation science. I'm sure most of you are familiar with Kaiser Permanente. We provide the full scope of care, inpatient, outpatient, emergency care, and behavioral health, and we have a fully implemented electronic medical record. What that means is that it's a perfect environment for trying out new models of care. And when you're successful, it has a pretty large reach because we care for actually 9 million members and have 17,000 doctors. And the models that we create are often ones that can be adopted and used outside of Kaiser Permanente. So in the 1990s, almost every health professional organization did a call for action to improve identification of intimate partner violence. Unfortunately, not much happened in terms of change. And so in 1998, we decided to take a different approach and look towards something beyond just clinician training. And we decided to select one facility, and pilot a new approach, which was the systems model approach, also known as the precede-proceed model, that had a very strong evidence base. And that model, the idea was that we would use the entire healthcare environment, not just clinicians, and that our goal was to make improving intimate partner violence services part of everyday care. The pilot was evaluated through this researcher-clinician partnership because we wanted a really rigorous design, but we also wanted something that was both clinically and operationally meaningful. We wanted to find out, does this model change physician behavior, and does it change patient experience? And the pre and post implementation evaluation showed a dramatic and statistically significant increase in screening, identification, and referral. It boosted member satisfaction with the health plan, and it was well accepted by clinicians. So that led us to the next step, which was to see if it could be adopted in 6 more facilities in Northern California. And when that was successful, it was disseminated through all 40 of our facilities. Now, some words about data and measures of success. When a clinician sees a patient and identifies that intimate partner violence is going on, they put in a code for intimate partner violence that goes into the automated diagnostic database. And then we can use our already existing outcome measurement systems to provide data on whether we're making progress over time at increasing the identification of intimate partner violence. We can look at how that compares between medical facilities and how that compares between departments. Making improving intimate partner violence prevention a quality metric makes it look and feel like the other clinical quality improvement measures that we do, such as those around asthma, hypertension, and diabetes. So what does the data show? Over the past 12 years, we have identified 50,000 Kaiser Permanente patients who are experiencing intimate partner violence. And the majority of those have had follow-up in behavioral health. When we started in year 2000, 1,000 patients were identified, primarily in the emergency department. Last year, 2012, over 7,000 members were newly identified as experiencing intimate partner violence, and the majority of those identifications took place in primary care and mental health. Since we know that the prevalence of intimate partner violence has not been increasing, thank goodness, this suggests that we're doing a much better job at recognizing it, and we're recognizing it earlier before people present with serious injuries. This is what it can look like when you bring something like this issue into everyday care. So I mentioned the automated diagnostic database. That's an example of a technology enabler. Another technology enabler is the electronic medical record. We have tools that help clinicians identify, intervene, document, refer, and follow up. That's one of the learnings from implementation science, is that you want to use the already existing tools in that organization to embed it in the regular work. Having an electronic medical record that's adopted throughout all the facilities has also helped with dissemination, not just through Northern California, but across all of our regions. And with the successes that were present in Northern California, all of our other Kaiser regions have adopted the systems model process. They have champions and multidisciplinary teams, are using the tools in the electronic medical record, and are collecting data and seeing improvement. So there's often a tendency to dismiss the successes that happen in the Veterans Administration or in Kaiser as something that can't be implemented anywhere else. And I wish we had more time today to share with you what this model looks like as it's been implemented in other healthcare settings, both here and abroad. But I think I'll stop at this point. I'm sure there are many questions that you have for both of us, but I hope this example of practice-based evidence will help the IOM understand how do we begin to bring the learnings back in that really make our science more robust and will help us have better recommendations as we move forward in really being effective at reducing violence.